in the absence of active clot clot formation. What heparin does is that it activates antithrombin C and augments its function. So what we'll see is that in the presence of heparin, antithrombin 3 will have a higher level of activity. Okay, hence it will stop these clotting cascades from being activated. Okay, and that is why we used to give it in people that have COVID. Okay, and do you know why we used to give it to people with COVID? I'm sure someone has joined the two. We want to prevent clot formations. Why are we giving it in COVID? So remember that COVID in certain patients was found to have increased risk of blood clotting phenomena, right? Such as forming a deep vein thrombosis, okay, pulmonary embolism, okay, which are life-threatening conditions. Okay, so in certain groups of people, we actually used to put these people on heparin, right? And this is why we put them on heparin, so that it increases the activity of antithrombin 3, so that antithrombin 3 will actively surveil your blood to see that any activated factors are directly inhibited, hence preventing the formation of clots. Okay, right? Understood? Why is the class quiet? Yes. Kindly be a little louder. So you see, that's what we're saying. Antithrombin 3 on its own it doesn't essentially need an activator. It will work in the presence of activated factors to degrade them. That's what I'm saying. But heparin will sort of accelerate the activity of antithrombin 3. What heparin actually does is that it increases the binding of antithrombin 3 to these activated factors. It increases the affinity of heparin for these activated factors. Yes?
We don't have a condition where antithrombin 3 is in excess and a clot is prevented, while all the clotting factors are present in a person.
Yeah. So theoretically, such are what we call, your bleeding diaphyses. However, an excess of antithrombin 3 is not a disease I have personally come across or read, but theoretically that is possible. Okay, it's not a defect that is probably reported, but it probably exists. But theoretically, you're right. Okay. Why is the class quiet? Or is it the environment which is quiet? Because it's usually not this quiet. Yes. Okay, we are talking about anti-clotting mechanisms that is out of context. Okay. Right. Yes.
What would happen in a case where heparin is administered wrongfully to someone who doesn't have clot?
They'll start bleeding. They can start spontaneously bleeding. Wherever. Yeah. You want to give someone heparin? Okay, so let's talk about the other plasma inhibitor. We're talking about protein C. Okay? Now, protein C slightly differs from antithrombin 3 in its activity. Protein C is very specific to the inhibition of two factors, factor 5 and factor 8. Now, do you understand why the function of protein C is now very important? Because we're saying that in the presence of factor 5 and factor 8 is when the entire clotting cascade is accelerated, isn't it? So hence, we see that the inhibition of factor 5 and factor 8 becomes a very important anti-clotting mechanism, right? So, let's see how it does so. So, by the way, protein C is a vitamin K-dependent protein. We'll talk about this very soon, okay? Now, what it does, and this picture should be from Ranong, if I remember correctly, okay? You see, I'm 7th here, but I remember where these pictures are from. So it's about memorizing these things, about reading repetitively. Okay. So yeah. It's from Ganong, isn't it? It's from Ganong. Yeah, but yes, no.
Question. People used to tell us to say that when you move for a long time under the sun, then you start breathing from your nose. So is there a mechanism that causes people to breathe from the nose?
That is out of context of our our discussion. But if there's time at the end of the lecture, maybe we can talk about it. Okay? Yes. Okay. So anyway, that was just a light moment. So I was saying this picture is from Ganong, and the reason I mentioned it is a very important thing. Okay. They used to bring this picture. They would just remove a few things there, and you have to write what's missing. Okay. So you see, how protein C works is that protein C, in its natural form, is found inactivated in plasma. Okay. Now, in the presence of thrombin, you see, and thrombin was coming from where? The clotting cascade, isn't it? In the presence of thrombin and another protein called thrombomodulin. Thrombomodulin is a protein receptor found on endothelial cells. Okay. So, in the presence of these two, protein C is activated to activated protein C. Now, the ultimate goal of protein C is to inhibit factor 8, to inactivated factor 8, factor 5 to inactivated factor 8, factor 5, and to activate plasmin. Now, it will directly inhibit factor 8, it will directly inhibit factor 5. What's interesting is how it leads to activation of plasmin or plasminogen to form plasmin. Now, what is plasmin? Does anyone have an idea what plasminogen or plasmin is? Anyone? Okay. So you see, what plasminogen? Anyone? Any of us? Yes.
It digests the fibrin.
Okay, that's correct. So it's an enzyme that will break down your fibrin clot. Okay, remember the fibrin clot was the end product of the clotting cascade, isn't it? Now, what's going to happen is that the fibrinolytic system, remember, is the main anti-clotting mechanism that we are leading this discussion to, right? So plasmin, the activation of plasmin is very important to the fibrinolytic system, which is basically the breakdown of this fibrin-based clot. Now, plasminogen is activated by a factor called TPA, tissue plasminogen activator. Understood? Now, TPA is found in serum, okay, in plasma. However, in the absence of this cascade, in the absence of protein C, TPA is inhibited. You get my point? TPA works to activate plasminogen to form plasmin. However, TPA itself must remain inactive, right? In the presence of any of these, in the absence of any of these triggers. Now, TPA is inhibited by inhibitors of TPA, and these are called plasminogen activator inhibitors, PAIs. Okay, there's PAI1, PAI2. They're not shown here, but you must know that there's an inhibitor for TPA. Okay, so TPA is always kept inactive. Now, what protein C will do is that when protein C is activated in the presence of thrombin and thrombomodulin, and remember, this will only happen if there is an actual clot that has been formed, right? So protein C is only activated when a clot is formed, so the thrombin exists to activate it. And we said that it will inactivate factor 5, it will inactivate factor 8. What protein C will also do is that, remember those inhibitors of TPA, right? Those factors that were keeping TPA inactive. Protein C will go and inactivate those inhibitors, right? So the effect will be that now that inhibitory effect on TPA will be released. TPA will be active to then lead to the conversion of plasminogen to plasmin, and plasmin will be the active enzyme that will go and break down the clot, right? So it will lyse the fiber, right? And the final product is what we call fibrin degradation products. Have you understood how plasmin works and protein C works? So I'll take you through it one more time. Remember, the activation of plasmin is the ultimate thing what we're looking for here, right? Because plasmin has to go and break down the clot. Plasminogen in serum is found, and it is found in it's an inactivated protein, right? Its active form is plasmin. Plasminogen is activated by tissue plasminogen activator. But even tissue plasminogen activator is normally kept inhibited by inhibitors of plasminogen activators, PAIs, plasminogen activator inhibitors, right? The role of protein C, or activated protein C, will be that activated protein C will inactivate the inhibitors of TPA, which will then lead to the ability for TPA to activate plasminogen to form plasmin. Then plasmin will go and break down the clot. And notice that all this is started by the presence of thrombin. And thrombin only came because there was a clot. Right? So that is how you see homeostasis is achieved. Right? There was an injury, the clot was formed, the repair occurred, and the clotting mechanisms form the trigger of the mechanisms that will go and break down the clot to reinstate its normal, reinstate the normal physiology, isn't it? Normal physiology doesn't involve a clot being there, right? Understood, right? So the entire physiological or homeostatic process must involve the formation of the clot, the repair of the damage, as well as the breakdown of the clot to reinstate the original function. Right. So that's the role of protein C. Okay, and this is basically what we've been talking about. Now, there are some other plasminogen activators. TPA is the most important one. However, there is also a urokinase plasminogen activator. Bacteria such as streptococci also have a plasminogen activator called streptokinase. Okay, so all these will work to activate plasminogen to plasma. Okay. Have you guys ever heard where we use TPA? TPA in clinical medicine. How many of us know Sir Alex Ferguson? We know Sir Alex Ferguson, right? So remember, I think in 2015, 2016, Sir Alex Ferguson suffered a stroke, right? But he still goes to watch Manchester United, right? No deformity at all. Thanks to TPA. You know what they do? What happens in a stroke? It's basically a clot that forms in one of your blood vessels, isn't it, in the brain? So within 4.5 hours, ideally within 3 hours, from the onset of this stroke, if you administer TPA, okay, it can break down the clot. Because remember, that clot is essentially fibrin, isn't it? So we can make TPA, okay, and we can administer it, okay? TPA drugs called things such as alteplase, belteplase. Okay, we can administer it, and they will go and break down that clot. Okay, and that's what saves Alex Ferguson. Okay, what do you think would be disadvantages of giving someone TPA? If you are seated here, I give you TPA. What can happen? You will bleed. Okay, because it will then inactivate all clotting mechanisms. Okay, and you can spontaneously bleed. So it's a lifesaver. We don't use it in Zambia, because we don't have the facilities to, to monitor our care and the like. But TPA is a lifesaver, and its clinical uses in, strokes, people that suffer myocardial infarctions. So you administer it in a certain time period, you'll save a life. Okay, that's all we're talking about. Heparin, we already talked about it. Remember that it promotes the antithrombin 3 activity by promoting the binding of antithrombin 3 to the factors that antithrombin 3 will impact, right? Which are factors of the intrinsic pathway. Right, so some other anticoagulants. Sodium citrate. Now, sodium citrate is an anticoagulant. It prevents coagulation. It's not clinically used. Do you know where we use sodium citrate? It's used in blood collection bottles. Okay? So let's say you want to collect blood, okay? But you don't want it to clot. Right? You can put an anticoagulant in there. One of the anticoagulants we can put is sodium citrate. You know what it will do? It will do? Because remember, if blood is put in a test tube, it will be, remember, the test tube basically serves as a trigger to the activation of the intrinsic pathway, isn't it? Right? That's true. And that will lead to the clotting of blood. Right. So what happens is that you put an anticoagulant in this bottle, such as citrate. What citrate will do is that it will chelate, you know chelation, isn't it? You're doing organic chemistry and the like. So it will chelate the calcium within blood. And remember that calcium was very important for the formation of blood clots, right? Because it's a cofactor. So sodium citrate, EDTA, those are chelating agents that are also have anticoagulant properties. Okay. Right. So the other anticoagulant that we'll talk about is warfarin. Okay. Have we heard of warfarin before? This is another very common anticoagulant. Okay. It belongs to this class of anticoagulants called coumarin derivatives. Now, remember we were saying that protein C is a vitamin K dependent clotting protein, and there are other vitamin K dependent clotting proteins. Okay? So, what vitamin K does is that, you see, factor 2, factor 7, factor 9, and factor 10, and these you must remember, okay? You find it true or false question, which of the following are vitamin K dependent clotting factors? Factor 1, factor 2, factor 3, then you put true or false. So just remember this. 2, 7, 9, 10, as well as protein C and protein S. So, the role of vitamin C is that, remember that these are proteins, isn't it? And proteins undergo post-translational modification, right? Now, these specific clotting factors undergo a type of post-translational modification called gamma carboxylation, okay? By this enzyme called gamma glutamyl carboxylase, okay? Now, the function of gamma glutamyl carboxylase is dependent on the presence of vitamin K. Vitamin K works as a cofactor for the gamma carboxylation of these vitamin K dependent clotting factors. What it actually does is that in itself it becomes oxidized in this reaction, while the gamma carboxylation reduces these clotting factors to form their active forms. Okay? Now, vitamin K is needed in its reduced form for it to become oxidized after this chemical reaction. So when vitamin K is in its oxidized form, which is called vitamin K epoxide, it needs to be taken back to its reduced form so that it can serve again in this reaction as a cofactor, isn't it? And the enzyme that does so is called vitamin K epoxide reductase. So this enzyme is very important to the reduction of vitamin K, which then is important for the gamma carboxylation of these vitamin K dependent cofactors, clotting factors. So what warfarin does is that it will go and inhibit vitamin K epoxide reductase. Understood? Essentially blocking this whole chemical reaction. And then you'll see that the formation of these clotting factors these clotting factors will be formed, but they will be inactive because they won't go that final post-translational modification. Understood? Right. So when you give warfarin, it will then lead to the inactivity of factor 2, factor 7, 9, 10, as well as protein C and protein S. You must remember which are vitamin K dependent clotting factors. Right. And then we look at the role of endothelial cells in anti-clotting mechanisms. Okay, remember we've already discussed most of these. Your plasminogen activators are produced by your endothelial cells. Remember your TPA, urokinase. Thrombomodulin, remember we said it's a protein that is found on your endothelial cells. And what was the role of thrombomodulin? We said that it works with thrombin in order to lead to the activation of protein C2, activated protein C, which is very important for fibrinolytic pathway. Right. Your endothelial cells also produce certain factors such as prostaglandin I2. It's also called prostacyclin. Okay. Now, prostaglandin I2 is an antiplatelet factor. Okay, it prevents the aggregation and activation of platelets. Okay, which then prevents the formation of a platelet plug. Right. So that's some of the roles of endothelial cells. Okay, you may get a short note what are the roles of endothelial cells in anti-clotting mechanisms? Just this slide. Right. Let's finally also look at the role of aspirin. Anyone of us have relatives that take aspirin because they have some heart condition? I'm sure. Yeah, right? Do you mind telling us why they take aspirin, or if you have? But you know they take aspirin, right? Almost on a daily basis. They take it daily, right? Yes, with the BP tablets. Okay. So you see, people that are hypertensive. Okay, we know what hypertension is, right? Raised BP. Now these people are prone to a disease called atherosclerosis. Okay? Atherosclerosis is nothing but the formation of these fat plugs in your blood vessels. Now, the ones we're worried about is your blood vessels that supply your heart. Okay? Now, the danger with atherosclerosis is that once this plug, you see, you have a blood vessel, and then there's this fat plug due to atherosclerosis that's forming in there. Once this fat plug disrupts, okay, platelets will go there and get activated, okay? Because you have exposure of subendothelial collagen, isn't it? So platelets will go there and get activated. Now remember that for the activation of platelets, you need this factor called thromboxane A2. We mentioned it, remember? It's a component of your alpha granules in platelets, and we talked about alpha granules. Now, thromboxane A2, okay, we won't go into much detail, but it comes from a certain pathway, right? Which is inhibited by drugs called non-steroidal anti-inflammatory drugs called NSAIDs. Okay, and aspirin is an NSAID. Okay, hence aspirin is used to inhibit the formation of thromboxane A2, which will then prevent the formation of active platelets, right? Hence preventing these clots from forming. Right? So that is the anti-clotting mechanism of aspirin. Understood? It's not something, this was an additional thing that I put, but it's just something that's interesting to know because we are talking about anti-clotting mechanisms, okay? Right. And that is the end of blood physiology. Any questions? Yes. Okay, let's come down.
Ma finisce in via 4 you know what's the junction? Then thinking about your vision. Huh?
Okay, let's hear a question, very interesting question. Saying that if there's already a mechanism of getting rid of blood clots, right? Why then do we need anticoagulants? Right? So you see, these mechanisms are there to prevent blood clots that are physiologically formed, right? But there are disease states where blood clots are formed pathological, okay? And that's why we need anticoagulants, right? Because your normal anticoagulants mechanisms are not sufficient. Okay. Yes, yes, sir.
How can we classify aspirin? Is it a plasma inhibitor?
It's an antiplatelet drug. Antiplatelet. It inactivates platelet function. Yes. Understood? Okay. Yes. Yeah. So the presence of thrombin will determine how far this clot will form, right? And that is why the function of antithrombin 3 is very important. Because remember, antithrombin 3 will lead to the inhibition of those factors that are activated by thrombin. Okay. Right. So, okay. Sure. Uh-huh.
And then when you look at factor 8 and 9, when somebody is lacking factor 8 and 9, to cause hemophilia A.
Yeah.
So can you say, is there any chance whereby if you have excess of antithrombin 3, you can have hemophilia?
No, antithrombin 3 doesn't inhibit factor 8. The clotting factors of the intrinsic pathway, 9, 10, 11. Now, yeah, what we are saying is that they are what we call acquired hemophilia, okay? You can have an acquired hemophilia where, for some reason, there's a drop in your factor 8, factor 9, due to whatsoever reason, okay? And yeah, you can have what we call acquired hemophilia. Yeah. Yes. Yeah. Yes, they are part of the homeostatic processes that will prevent the formation of blood clots. Yes. So another question. Write short notes on the activity of toning. Okay. So take down these questions. Yes, Doc. Yes. Okay, let me just summarize what Wafering does. Vitamin K is important for the proper formation of your factor 2, factor 7, factor 9, factor 10, protein C and protein S. Alright. Vitamin K is essential for these proteins to be formed. You get my point? And how it participates in the formation of these proteins is by post-translational modification. So even after these proteins are translated, they need to be modified to become their active forms. Okay? And that's the role of vitamin K. Now, what warfarin does is that it will go and inhibit this enzyme which activates vitamin K. You get my point? Essentially, reducing the activity of vitamin K, hence leading to the improper activation or improper formation of your vitamin K dependent factor, which is 2, 9, 2, 7, 9, 10, and protein C and protein S. Hence it becomes an anticoagulant. Okay? Yes? Yeah, sure. Which one? This one? The first one. Sorry, come again. Yeah. Yeah. Yeah, so you see, it's just that this diagram doesn't depict it, but phospholipids, calcium are needed at all reactions of both the intrinsic and extrinsic pathways. They are cofactors of all the clotting pathways. Yeah. Yes. Protein C inhibits protein Z. I've never heard of protein Z. Where did you hear about it from? I have not come across it, and I don't think it would be very important for you to pass in the test. Yeah. Okay. So let us maybe after one more question review what we are supposed to know at the end of blood physiology before we move on to the next. Yes. Sodium citrate, yes. Yeah, oxalate is used, but its function is more related to preserving glucose metabolism. So when we have, preserving your blood using oxalate, we use it to actually prevent reactions of the glycolytic pathway, so that glucose is not metabolized. Yeah. No. They are not clinical use. Yeah. Yes. Yeah. So you have things such as prostacyclins, prostaglandin I2. which is an inhibitor of platelet activation. Yeah. Okay, let's review. Yes. What? What proteins? There are a number of proteins that are produced by platelets. Remember, we listed them down when we were looking at. Did you come for the lecture where we did platelets? So, unless you now show us that question, maybe there were those that are not formed by platelets, which were mentioned there. But remember, platelets are involved in the formation of certain clotting factors, especially fibrinogen, thrombin. They also produce growth factors such as platelet-derived growth factor. They also produce certain produce certain fibroblastic growth factors, right? Such as protein-derived fibroblast growth factor. Okay, as well as other, they form a lot of things. So I wouldn't know how to answer your question unless we maybe see it and then sort of try and eliminate which ones are not formed by platelets. Okay, yeah, let's review blood physiology. So there's sort of like a checklist that we have that you're supposed to know. I can't see it yet. Okay, so when we talk about blood physiology, remember we started by looking at the components of blood, characteristics, the functions of blood. So we did that. Remember, formed elements as well as plasma. We looked at what are the formed elements, how are they formed, what is plasma, what is it comprised of, okay? And then we went into a little more detail by looking at, okay, if we put this blood in a centrifuge, we split it, what are we going to have? And remember, we have plasma, your buffy coat, as well as your red cell mass, right? And then from there we can calculate your hematocrit. Hematocrit is basically the volume of blood which is occupied by your fat red cells. Then we looked at functions of blood. These are things that you can get as short notes. Okay, we'll write about functions of blood. Okay, I don't think we do need to go through any of these. This is basically a checklist just to make sure that we've gone through everything I've shared with you, so that even as you study, you make sure that you go through these things. Okay. Yes, then we looked at red blood cells. We looked at their structure, right? Remember there was that diagram where we described what is the structure of a mature red blood cell. We again looked at the functions of red blood cells, which are now, you see, if you understand the functions of blood, then you simply just need to know from functions of blood, what are the functions of red blood cells, okay? And basically, it's just repeating from there onwards, okay? We looked at the structure of hemoglobin, and then we looked at hematopoiesis, right? Where we specifically focused on erythropoiesis, looked at the different stages of how a red blood cell matures from its blast stages into a mature red blood cell, okay? We looked at the various factors that are necessary for the formation of hematopoiesis. Remember, we looked at the role of erythropoietin. We looked at the role of maturation factors. Which ones are the two maturation factors that we talk about? Vitamin B12, folate, okay? And we also looked at the function of other elements such as iron. Iron is needed for the formation of hemoglobin. Additionally, you need vitamins in order to, serve as cofactors for these processes of erythropoiesis. The regulation of erythropoiesis is what we talked about when we talked about erythropoietin, right? How is erythropoietin triggered? What is the role of erythropoietin on erythropoiesis? Yeah, that's what we talked about. This is iron, other B vitamins. Right, so when we talk about erythrocyte disorders, I remember we mentioned a little on your polycythemias. Anemias, we did mention it a little, but we didn't talk about it much in detail, so let me just give you a brief review of what anemias are, but you don't expect much questions on anemia, right? That's more of pathology rather than physiology. Okay, so anemia is basically a state of either reduced red cell count, reduced hematocrit, or reduced hemoglobin, right? Which is basically defined or characterized by the inability of blood to carry oxygen, right? Majority of the symptoms of anemia will arise because of inability to carry oxygen, okay? So what do you think would be some of the symptoms? Let's say you get a scenario, okay? How would you tell from this scenario, this looks like an anemic patient in this scenario? So you see, that's how physiology questions will come, okay? They'll put they'll put symptoms for you, and then the questions will be based on physiology, okay? But you need to understand what's going on in the scenario, isn't it? So, someone with anemia, how we look at it is that we can classify the symptoms, because anemia is going to present with symptoms from all systems of the body, isn't it? So you can talk about, okay, what will be the CNS symptoms of anemia, right? People who have, someone who has a headache, because there's reduced oxygen going to the brain, okay? They'll have dizzy spells, okay? They'll have fainting spells, okay? Then we look at the cardiovascular symptoms of anemia, and those are the most important, right? So someone with anemia will have palpitations. You know what palpitations are? The feeling of your heart racing, okay? And why will that happen? Because your blood has reduced oxygen carrying capacity. So through mechanisms we won't go into, this person will start beating, their heart will start beating faster, okay? In order to sort of pump more blood to tissues. You get my point? So they'll have palpitations, someone will get easily tired, okay? They'll have difficulties in breathing, okay? So those are some of the cardiovascular symptoms of anemia that we talk about. And those are the most important. So dizziness, headaches, easy fatigability, difficulty in breathing. When you look at this person, okay, they will look pale. You get my point? Have you ever seen a pale person? You've seen a pale person? Okay. So those are some of the signs and symptoms that you may, will tell you that this is what they are talking about is anemia, but not the most important thing for you to know. When we talk about causes of anemia, okay, you must think of two things. Either one, the bone marrow is not producing enough red blood cells, or two, red blood cells are being produced, but they are being destroyed at a fast rate. Okay? So there are only two things that can happen. Okay? So if we talk about the bone marrow not producing enough cells, right? Or it's producing defective red blood cells. That's where we talk about iron. Let's say someone has iron deficiency, right? So that's where iron deficiency anemia falls. And I remember we gave some examples of who will get iron deficiency anemias, right? Let's say a woman that is excessively menstruating, right? Because iron is not going to be retained, she will continuously lose iron, and that's what leads to iron deficiency anemia. I hope you remember the type of anemia that someone with iron deficiency will get. Who remembers when we look at the MCD and MCA? We talked about this. They'll get a microcytic hypochromic anemia, isn't it? Why will it be hypochromic? Because iron is necessary for the formation of hemoglobin, isn't it? Hemoglobin is what gives the color to these red blood cells. So if there's reduced hemoglobin, this cell will be hypochromic, right? In addition to that, if there's a reduced hemoglobin content, this cell will be smaller than its other cells, and hence it will be a microcytic cell, right? We talked about these guys. Okay. Other causes of defective red blood cell formation, remember if someone has a B12 deficiency or a folate deficiency, what kind of anemia will they get? How will the cells look? Macrocytic, isn't it? They'll be bigger than normal, isn't it? Right? And why is this so? Because B12 and folate were what we call maturation factors, right? And what did we say the importance of maturation factors in erythropoiesis was? For DNA synthesis, right? And DNA synthesis is important for cell replication, right? So now, in a case where you are lacking folate, you are lacking B12, the cells in erythropoiesis will not replicate as they are supposed to. And remember, as they replicate, they are supposed to shrink in size. So that will not happen. Hence, what you will see being released into blood are big cells, macrocytes, isn't it? So microcytic anemia, those two things you shouldn't forget. Okay. Dr. Windy last year he brought a question. You have to calculate MCV, MCH. Then based on those, you will say what kind of anemia is it and what can cause it. Okay. So it was sort of working backwards. Here we're saying from the cause, what kind of anemia we'll get. There they were saying, okay, you have these kinds of cells. Can you calculate the MCV? Can you tell us what is it, microcytic? And then can you tell us what can cause this? You get my point? It all comes from your understanding. Still talking about the inability of bone marrow to form red blood cells. Let us say your bone marrow becomes infected, or there is a toxin that is suppressing your bone marrow. You get my point? So it's producing red blood cells, but it's not just producing them at a fast enough rate. Okay? So what kind of anemia will such a person get? The cells will just look normal, isn't it? It's just that there's reduced production of these blood cells, isn't it? Understood? Okay? The other one is, let's say, and this of course goes to increased loss of, to the other side of the causes. Remember we were saying either there is reduced production or increased destruction or loss of red blood cells. So let us say on the other side where we have increased loss of your red blood cells. Say I'm coming here, I fall off these stairs, I fracture my femur, I lose 3 liters of blood. I'll be anemic, isn't it? That is acute hemorrhage, isn't it? But if I look at my cells, what will my MCV and MCH be? Just be normal, isn't it? Right? Because there's nothing that is affecting how my bone marrow is forming these red blood cells, right? Yes. Okay. Then under increased destruction of red blood cells is where we also have hemolytic anemia, isn't it? Right? So let's say someone has malaria. Okay, remember malaria destroys your red blood cells and you can become anemic, isn't it? That's a hemolytic anemia. Okay, just an overview. Okay, just a very brief overview of what you need to know about anemia. Okay, right. But again, I cannot overemphasize the need for you to know about iron deficiency anemia, as well as B12 and folate deficiency. And you remember what is pernicious anemia, isn't it? Yes. Polycythemia, we talked about this, nothing much I will bother you with. Then of course we talked about leukocytes, their structure and function. We went into much detail talking about each of these leukocytes, what is their function, how do they look, okay? So we won't dwell much on that. Disorders of leukocytes is something you can sort of like leave out for now, okay? Just even you can just go through it from this slide, but it's not something you're expected to know that much in detail. Platelets, very important. So you need to know what is the structure of platelets, right? How are they formed, right? We talked about thrombopoiesis. What are the contents of platelets, right? When we talk about platelet function, how is the platelet plug formed? Remember, we talked about platelet activation, platelet aggregation, right? Platelet adhesion and platelet aggregation. Okay. So you need to know about formation of a platelet plug. Plasma, this is something we did very, very well in the first tutorial. And then, of course, hemostasis, right? And when you talk about hemostasis, you talk about the 3 processes. You need to know that there is going to be transient vasoconstriction, formation of the platelet plug, and coagulation, which is secondary hemostasis, right? Platelet plug formation is primary hemostasis. And when you do all of these, you talk then about your anti-clotting mechanisms and disorders of hemostasis. Again, you don't really need to get so much into detail for all this. Even you can just read it through this summary that has been made, and that should be enough. We talked about blood typing and blood transfusion, right? The ABO system as well as the rhesus system. Okay, so you need to know what is the ABO system, how are ABO blood types inherited, okay, what is the rhesus system, how is it inherited, and who can receive which blood, right? And this all is nicely summarized in this in this document, which I'll share with you. We talked about hemolytic disease of the newborn, right? This is the disorder where you have an Rh negative woman who has a child which is Rh positive. Okay, and how that causes a disorder. Right. Diagnostic blood tests. Just know the ones we talked about. Remember, we talked about your blood indices. That is something very important for you guys. You need to know how to calculate them. Okay. It's there in the slide. We gave examples of how to calculate these indices. Okay. And that's basically what you need to know about blood physiology. Okay. Any questions on any aspect of blood physiology before we take a 5-minute break and then complete neuromuscular? Yes. Sorry? How? No. Can't make us show blood. Yeah. So if there are any questions, you can stretch out right now. If you want, you can come here and ask me. Let's take 5 minutes and then we get into the last topic.